Work. Great. Well, thank you and welcome everyone to the April 19th edition of the Provider Update. I want to kind of apologize in advance because our internet and email have been down all morning, so some of the slides will look a little bit half-baked, but hopefully the main point is there. And we can certainly do questions at the end. Getting started, just with a general overview, our timeline continues to grow, but the main thing, and I think this happened on the day of our last meeting, the sotrovimab EUA was revoked by the FDA, and that was across the country because the predominance of the BA.2 variant, and sotrovimab does not have activity against BA.2. So that option is off the table for treatment. In just kind of not a lot is new on the vaccine front, but what is new since the last time we met on April 13th, the CDC extended the mask mandate on public transportation through May 3, and then as most people probably heard, it was struck down yesterday by a federal judge. So on airplanes and trains and buses, now you do not have to wear a mask. CDC had, obviously cases are down everywhere. There's some areas where there's an uptick, but CDC had basically extended it. It seems like the main argument was just trying to give it a little more time to see what the impact of BA.2 was going to be. But that's where we are now with that mask mandate. On April 14th, the FDA granted an EUA for the first COVID-19 breath test. This doesn't look like it's going to be something that's sort of super immediately useful and practical for all of us. This is a picture here on the right of what it looks like. So the size of small carry-on luggage, they said, but, just kind of, I guess, cool technology that's happening. It's called the Inspector COVID-19 Breathalyzer Test. It does have to be done, with trained clinical personnel. It's not a take-home test. The results are in 3 minutes. It was 91% sensitive and 99% specific, at least in the initial data that they presented. And it's basically detecting 5 volatile organic compounds, or VOCs, associated with SARS-CoV-2 in exhaled breath. So anyway, sure would be nice if it was a little bit smaller. I think they can make 100 of these devices a week. So again, it won't have a huge impact, but just good to see, the options continuing to proliferate. On April 15th, the governor did renew the New Mexico public health order through May 16th, and really nothing changed in that. In certain settings, masks are still required, and in certain settings, testing for unvaccinated people is still required. On April 20th, which is tomorrow, the ACIP has a meeting scheduled. A little unsure what that agenda will be, but and not even clear that it involves COVID vaccine, but it might. One other thing I'll just say, completely unrelated to COVID, but I thought it was interesting. The World Health Organization is looking into cases of severe acute hepatitis in children in the United Kingdom, Ireland, and Spain. And then there were 9 cases in Alabama. The CDC has reached out to all the states. I think looking through our EPI department looked through its data and didn't see any red flags for cases in New Mexico, but it's definitely grabbed people's attention. It does not seem to be, I think COVID's sort of been ruled out as, both vaccine and testing as a reason for this, but adenovirus remains on the list of possible etiologies. So anyway, community transmission across the US. This is the one that is, kind of labeled for use by healthcare facilities. In the upper right here is data from 2 weeks ago, and you can see, like, through the middle of the country, it's getting more blue, which is the better color. But I think what is interesting here is looking in the northeast part of the United States, Maine to New York, that is becoming redder, so more community transmission. And again, the metric on this map is cases and percent positivity. On the community level map, also done by the CDC, and again, the metric on this is cases, but the threshold's much higher, and hospitalizations. So same basic picture, it's moving, greener and greener, except for in this northeast corridor of the United States, so Maine and really looking at New York. So so as we know, BA2 it's really everywhere in the United States as the predominant variant, but definitely in the northeast corridor is where it has the highest proportion of cases. So we'll look at that in just a couple of slides. So this is the New Mexico specific data. Our cases really look like they have, leveled out. We're not seeing an uptick. And again, behind all this information is kind of our general understanding that there's a lot more at-home testing being done. So if you're counting like absolute number of cases, yes, we are, counting fewer of them because most people don't report their at-home tests, positive or negative. But overall, we're doing enough testing to have a general, sense of surveillance across the state. I think the one thing that is maybe a little bit concerning is the infection rate, or the R effective, which is now up above 1 by just a hair, but it had been extremely low. So that's something to be on the lookout for. Again, that can indicate growing number of cases. So this is the BA2 map. Again, it gets updated every Tuesday, but this is actually from last Tuesday since the internet wasn't working this morning. And it was at 86% of cases. These are estimates the CDC now casts, but you can see up here in the Northeast corridor, it's almost all BA2. In region 6 where we are, it's still predominantly BA2. The numbers coming out of SLD, our state lab, would put us at a lower percent, like really under 50%. But again, these are all estimates. So one of the things I wanted to look at was just the impact of BA2. I feel like it's really hard. We hear cases are starting to go up, but maybe there's not that much impact. So on the COVID Act Now website, you can compare states. Since New York seemed to be the one with the highest, the most alerts on our CDC maps, I picked New York, and you can see this is the metric here is cases per 100,000. New York is starting to go up. New Mexico is staying steady. And then, maybe a little bit worrisome is that the hospitalizations per 100,000, looking at New York, also starting to tick up. But if you put that in the perspective of the past 180 days where we get to see the Omicron surge, New York's uptick, at least right now, is really a tiny blip compared to what we were experiencing during Omicron. So, we still don't know the future, but it seems that even in places that are seeing an uptick, Philadelphia went back to a mask mandate. I think it's good that we are cautious, but we're not seeing the takeoff that we did with Omicron. The other place that I feel like we keep looking to is the United Kingdom. So on the this is Our World in Data website, where you can compare countries. And so here's the United States in the reddish color, United Kingdom in the bluish color. We have kind of all along sort of said we're just a couple weeks behind what's happening in the United Kingdom, and a little hard to figure out what's happening here. We were a little bit behind them in terms of the Omicron surge. United Kingdom, is probably everyone has heard in the news, definitely had a second BA2 surge, but at least so far, we're not seeing that same bump. Maybe yet to come. Maybe we're more than a couple weeks behind, but that's where we are right now. On the vaccine front in New Mexico, we have had quite an uptick of vaccines given. So for the first week in April, we reached 25,000 vaccines. And again, that is compared to our nadir of 8,000 vaccines a week. But, up in here, we were doing 85,000 vaccines a week. And here in the peak April a year ago of 140,000 vaccines a week. And this is largely driven by that recommendation for the second booster dose. If you look at sort of, we do have reports of the number of first doses, second doses, third and fourth doses. On the vaccine front, what kind of what's out there is Pfizer booster doses for 5 to 11-year-olds. They did submit data to the CDC and seem to have show a very favorable immune response to a booster dose for 5 to 11. So that's, no action on that right now, but I think that will be in our probably nearer future than some things. And again, in New Mexico, we are still, barely at, I think we've just probably reached 40% for the number of 5 to 11-year-olds who have had one dose of vaccine. So it's not been a group that has had a huge uptake in vaccine. And then about 34% that have had the 2 doses. So fairly good follow through for people who started the series, but not a lot of uptake. The other thing our vaccine program sent along is the Pfizer expiry dates have been extended. So basically for the orange cap and gray cap, it was extended from 9 months to 12 months, the expiration dates, if they've been in the ultra low temp. And I did see Joelle's on the call. So Joelle, please jump in if I'm not representing this correctly. If you've had them in the refrigerator, no extension. And then here's additional information. And let me pause for just a second, make sure with Joelle that that's correct. Anything to add, Joelle? All right, maybe she wasn't on the call.
Dr. Edward, I can confirm that what you have is correct. It's
okay.
Only at ultra low temperatures.
Awesome. Thank you so much. Okay, so, and this is just from last time, the FDA approving those second booster doses. Here's what that's looked like in New Mexico. So this is kind of second boosters, which we are really counting as fourth doses. So we can't in the NMSA system separate out a fourth dose that was given as, to someone who's immune compromised from a fourth dose that's a booster. But just from time-wise, I thought it was interesting. We have our very first fourth dose given on 2/9/22. So that was definitely not anything that was particularly endorsed at the time. So there were people very early on working on getting extra doses, and then, just vaccine errors that happened. But so there's been this slow trickle. Here we start to see a bump from people who are immune compromised, who are approved for that third dose, and then starting in really mid-January, we're able to get a booster. So that was a fourth dose for them. But here, March 29th is when the second booster or fourth dose was approved for people 50 and over, and that's what this bump has been. So overall, it's at 40,000 fourth doses given. I think all along, another big question has kind of been that, are boosters worth it? Is a fourth dose worth it? What if you've had COVID already? Does that mean you don't have to get a booster dose? And, I think, I guess from, and not that I'm an expert, but just from kind of what I've heard and what I've read, I do feel like the question of a third dose has really been, or a first booster has been answered. And it probably really should be a 3-dose mRNA primary series. And that is that first booster dose or third dose really is useful at preventing the worst outcomes of hospitalization and death, even in people who have gotten COVID. So the MMWR just published this paper, and it is talking about that question of, if you've had COVID, is vaccine additionally protective? And the long and the short of it is it does seem to be, especially that third booster dose. And I know, like for Johnson & Johnson, the numbers are a little bit different. Overall in the state, we have such a small group of those. So I'm kind of, generalizing here. But if you started with an mRNA vaccine and got a third dose or a booster, that is the most protective, even if you've had COVID somewhere along the way. The Moderna 5 is, still seems a little bit unknown when we're actually going to see that. So it's not in the state yet. So we're just kind of keeping it on the watch list. I think one other thing that was in the news was just the news that the death rate in the United States compared to other large high-income countries has been higher through the Omicron wave and really through the whole pandemic than other countries. That's what this is from the New York Times vaccine tracker, but just showing that here's the United States, 20 deaths per 100,000 compared to other states, and sort of looking at why that might be. And one of the issues is our vaccine rate. And if you look here at the share of the population with a booster dose, it is much lower. So it's not all direct evidence and how important that first booster is. And maybe we'll start to feel that way about a second booster as well. But definitely those third doses, those booster doses are, I think, have the preponderance of evidence really is in favor of making sure people get that third dose. This is just the worldwide map, taking a look across the world at vaccine, because again, I think as we all think about variants, obviously stopping, and there just has been sort of an explosion of variants that are being watched by the World Health Organization: BA4, BA5, XE, XD. But is really trying to get the world vaccinated. So this beige color or the reddish color is low vax rates of about 20% to the dark green, which is the more highly vaccinated. But overall, 66.7% of the world's population has had one dose. So in some ways, like an amazing, like kind of mind-blowing number of people have been vaccinated, but still not really where I think we'd all like it to be. There's nothing really new on our vaccine watch list. I think we've talked about all of, actually, one thing we didn't talk about was the under 5. So Moderna and Pfizer both have data into the CDC or to the FDA for the under 5, and probably end of May, beginning of June, we might see some movement on that. That's our kind of latest update. The sotrovimab pause, we talked about a recurring theme here, that expiration dates, like really kind of across anything COVID, if you have something expiring, it's definitely worth double checking, because part of this EUA process is, companies are really working on extending their expiration date. So Paxlovid has an extended expiration date. Also, for people who are ordering meds through HPOP, there is a more, and again, not an area of expertise for me, but a more direct ordering, and our pharmacy team can help you through that. Also new is that Paxlovid, which does need to be renally dosed. So if you have a GFR between 30 and 60, it's essentially, instead of taking 2 pills, you take just 1. And so apparently people have been just popping out that and getting rid of that 1 dose. And I'm like, the name is escaping me of the medication, but of the 2 meds, one of them needs to be renally dosed. And so now there will be a renal dose pack. This is just a reference. We had it in the slides last time from the NIH treatment. And I think Chris can talk about this. I think he has a few updates, but the new, they redid the homepage of the Department of Health COVID website. This I actually took from Dr. Sosa on just because I love some of the data. I love the graphics that people put up. And this is just was an interesting study of comparing the symptoms of Delta versus Omicron, with really showing that, you know, most of them were fairly equal, except loss of smell and sore throat were significantly different. But so it's sort of interesting to look at, but mostly I just love the graphic. Our daily case counts and hospitalizations are now, they're not getting sent out every day as a press release, but on our website. And then another expiration date extension. So the state did distribute 2 million eye health tests, and that, you know, they're probably largely distributed, but if you have some still hanging around, their expiration date did, I think most of them are expiring in somewhere between March and May, and those expiration dates did get extended by 3 months. We talked about this last time, the quarantine and isolation calculator for the CDC, and that is it. Thank you so much. I'm going to stop sharing. And Chris, you had a couple updates, right?
Yes. I am not going to turn on my camera because I am in the middle of eating a sub sandwich. I'm sorry, but I will show a couple of the updates to the cv.nmhealth.org website. Can you all see the site? Let me try that again.
Yes.
Yes.
Okay, great. So we've really tried to simplify the information, breaking it down primarily into 3 different categories: testing, vaccine, and treatment, along with the contact information. For the providers, this is going to be a very helpful resource guide here. So the Department of Health has put together a really great toolkit that is broken into mask guidance, vaccine guidance, testing guidance, all of these different categories. And what we've tried to do is you can download the entire full kit here, and or download particular sections of the toolkit. This was put together by a whole host of people, but Dr. Patahon and Liesel are the ones that I know of that were really driving this. So they did a really great job getting all this together. And so if you go to cv.nmhealth.org, you'll be able to get the latest guidance in toolkit form here on the landing page. In terms of the vaccine tool, we are preparing for the next round of, I guess, age groups being approved, as well as boosters for those age groups being approved. So as the CDC and FDA approve various groups, will turn that functionality live in the app so that we can accommodate. We also, if those of you who are using the app, you'll notice if you've logged in recently, the system is asking you a question based upon whether or not you're going to be able to provide vaccine at no cost to individuals that don't have insurance. So if you could answer that question, what that's going to do is allow us to put together a resource for individuals that need to find locations where they can get the vaccine for free moving forward. So please answer that question as you go about your day. If the pop-up did not show up for you, it's just in your location details in the same area that you identify if you're going to accept social security numbers or the consent form. That's where it's at. So other than that, I will pause and turn it back over to Dr. Durham and or open it up for questions.
And there was just one in the chat about the, waiting 90 days after monoclonal antibody in the setting of giving a booster, but that's really gone across all doses of the vaccine and all brands of vaccine. So again, I think it's fair if someone's been sick with COVID and has gotten the monoclonal antibody and, wants to wait to, kind of feel better, by all means, they can do that, but there's no requirement to wait any number of days after they're out of their isolation period. And Tanya, are you able to
Yes, I
get
am.
on? Okay, hi.
I don't know if you guys can help me or not, but I just applied for my CLIA waiver. We're going to be ordering Acula rapid PCR testing for staff right now, because we know that the test sites are going to start ramping down, and we've had a lot of sick people, mostly with flu, so at least that's good. Who do I contact at the state level? Because it's in my waiver in, but I know even if I'm testing staff, I need to be reporting, since it's PCR, negatives and positives to the state. Does anyone know who I contact to get that set up?
I do. And it's, I think, probably the best bet right now, but anyone else should jump in, is Carmela Smith. Yeah, I'll connect you by email.
Okay, perfect.
And for sure she'll be able to tell you. But you bring up another point though, which is for not PC, for antigen tests, for negative results, the CDC said a couple of weeks ago, maybe as much as 3, that you no longer had to report negative antigen tests. And I don't think it's gone out as a HAN, but New Mexico is following along with that. ERD is following along with that. So PCR, you do still have to report positives and negatives, and antigen, you do have to report positives.
Thank you. And if it ends up getting where there's not a lot of test sites, we as a village may reevaluate if we want to open it up to public, but we'll just monitor that as it goes.
Great. All right. Yeah, and thanks for doing that. Very innovative. Is that going to be testing there at the fire station?
Yes, so
Okay.
we've been sending people when they come in coughing or sick to curative for either rapid PCR or regular PCR. And I've been trying to get PCR testing rapid for staffing for quite a while, but we are still mandating non-vaccinated get theirs every 7 days. And we know that funding is going to go away. And they're also not very good about doing it. So if we have it, it'll be easier, but we've seen an uptick in cases in Corrales, just like everywhere else. So just having that and working with the medical director to see if it ends up turning into testing patients, because we have taken quite a few of them out recently, older, unvaccinated, to the hospital pretty sick.
Great. You are also reminding me just to update on curative testing, which curative does have a contract with the state, as well as Vault, which is the one where you can order a test to be sent to your home, and then you do it by videos, but both of those are PCR options. That testing, so they had been, as part of their testing program, billing the HRSA program. When that HRSA funding went away, and that's for uninsured people. When that went away, the state did agree to pay for those vendors that are contracted with the state, did agree to pay the uninsured testing. So, and that's as long as the FEMA funds are available. So right now we are just looking to the end of June, but for the end to the end of June, Curative and Vault sites and Tricor and NetMed, which is a small group just doing some, I think, a little bit in Taos, Albuquerque, and maybe Las Cruces. But those ones are still being kind of, the uninsured testing is being subsidized by the state. So that is in place till the end of June, and then, you know, we have to see about what FEMA and state funds may be available to support uninsured testing. And again, I'll just make my pitch for, you know, anyone, insured or not, can order home tests through the federal program, the Biden administration program, and through Project ACT. Both, you can get to both of those through Find a Test NM. So again, I just feel like tell everyone, just order now and be ready. Let's see, what's there? Oh, and the other thing that has started to go into place is that all three Medicaid programs are, as we all know, insurance is supposed to cover the cost of 8 rapid at-home tests a month for people, but that was going to be, you have to buy them and get reimbursed by your insurance company, and that's you know, impossible as far as I'm concerned to figure out. But now for the Medicaid plans and some of the private insurance as well, you can go to a pharmacy and have the pharmacist basically put it through as a prescription. So it's billing your insurance company, but you're not paying out of pocket. So again, for patients on Medicaid in the state, I think that's a good option. It's a little more hit or miss for people with various private insurance plans, but worth asking before you shell out the money for home tests. Great. Are there any? Oh, hey, Dan.
Hey, just
Sorry.
popping back in here, but I think the insurance companies really, though, look at whether it's symptomatic or contact, and then they tend to pay for them. But the ones that are just for screening or surveillance, they're pretty unlikely to pay for them. So if you're just doing a once a week test to make sure you're okay, they're probably not going to pay for that with the insurance companies. And, you know, the state has been backing those up for the contractors, but we're going to stop doing that pretty soon here. So I think the ones where you're not symptomatic, those could be problematic for getting paid for.
Yeah, and I think that date is, that's the end of June date is how I understood it, but.
Yeah, if not sooner, but yeah, I think that's for sure.
Dr. Durham, you're on mute. Oh.
Let's see, is it safe to say if we have FSA, we can use this through a spending account for out-of-pocket costs for at-home tests? That is a great question. Does anyone have any experience with that? A flexible spending account? But I would imagine, yes, you might have to, it might have to be more because you're a contact or symptomatic. Don't know. But if you find out, we can try and do some research, and but if you find out in the meantime, Rhonda, let us know. Are there any other questions?
I actually have a question. It's for Chris. So in regards to the pharmacy availability for COVID treatments, how often is that updated on the website? Because I've prescribed some medications for COVID treatment, and I go on there and make sure, you know, I try to make sure that it's available. The pharmacy is listed, whatever's closest to the patient's home, and I'm getting all of these back. I went through like probably a week and a half where the patients are showing up and they're like, no, it's not here. So the patients are going to the pharmacies that are saying that they are carrying the medication, whether it's Paxlovid or the other, and they don't actually have them in stock. So my staff is having to call before I send the prescription, make sure that they in fact do have it. And so I just was curious to see how often that's updated.
Yeah, so I can connect you. Is this Suzette?
Yes.
Hey, Suzette. I can connect you with Courtney Lobato and the team, if you'd like. They're the ones who control the content on that particular directory, and they can give you the information that you need. I unfortunately don't have that.
Okay, perfect. And then just a comment in regards to Dan's little spiel. Travel too is a big one. The insurances are not paying for that, just to let you guys know. I have a lot of patients coming in and requesting that, and they're getting bills from, for the testing, just so you know, if you're not aware of it.
That is a great point. And yeah, if you get tested at the airport, I think it's like $100 out of pocket. So thank you for that, Suzette. And thank you for the people who chatted in. Barbara says the IRS states that COVID tests are FSA eligible medical expenses. And Cindy from Nambe Drugs, at the register, they do not pay. You have to submit your receipt to FSA for reimbursement. Excuse me. Great. Anything else? Dan, do you have anything else for the group?
Nope. Thanks for
All right.
checking. Yep.
All right. Well, thank you all for joining and spending your lunchtime with us. We'll plan on doing this call in 2 weeks. I don't think we anticipate anything big in that intervening time, but really appreciate, as always, all that you do and for tuning in. So thank you and enjoy the rest of the lunch hour.
Bye, everybody.
Bye.
Thanks.